Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Hello everyone, I'm Dr. Smily Sharma from India. In this session of Spin Academics, we are going to discuss an MRI approach to hypomyelinating leukodystrophies. Before starting, I wish to disclose that most of the images and the tables used in this presentation are from a recently published article in the Journal of Magnetic Resonance Imaging. In this presentation, we'll begin with discussing normal myelination briefly. Then we'll see how to recognize hypomyelination on MR. We'll look at few of the clinical features of these patients, and then using clinical features along with MRI features, we'll discuss a pattern-based approach to reach to a diagnosis in these patients. Hypomyelinating leukodystrophies are clinically and genetically heterogeneous diseases characterized by a permanent deficiency of myelin deposition in the brain. These children present with psychomotor regression but have a considerable clinical overlap. MRI brain is the imaging investigation of choice and may be the first to suggest the diagnosis. Specific MRI patterns along with clinical clues help to classify these disorders and guide genetic analysis, which ultimately is required to confirm the diagnosis. Moreover, recent advances have paved the way to quantify myelin, which can help in prognosticating these disorders and assess disease progression in the near future. Beginning with the normal myelination, myelin structure is composed of water along with fat, which constitutes 70% of the dry mass of myelin, and proteins, which comprise 30% of its dry mass. Myelin deposition leads to reduction of both T1 and T2 relaxation times and appears hyperintense on T1 weighted image and hypointense on T2 weighted image relative to the gray matter. The rates at which this happens are different, and T1 shortening caused by myelination appears earlier and quicker, whereas T2 shortening is a more gradual process. Therefore, T1 weighted sequence is used to assess myelination in the first 6 to 8 months, whereas T2 weighted sequence is useful for assessment of myelination beyond 6 months of age. According to the fundamental law of myelogenesis by Paul Flechsig, normal myelination occurs in a precisely organized temporal and spatial pattern. It occurs in a central to peripheral, caudal to cranial, and rostral to ventral organization. Now, there is a famous myelination clock which helps us guide the various structures which get myelinated at different ages on both T1 and T2 weighted image. In general, the structures which are myelinated at birth include the dorsal brainstem, the posterior limb of internal capsule, and the perirolandic white matter, and these are the early myelinating structures. As compared to the normal myelination, hypomyelination shows mildly hyperintense signal of the white matter on T2 weighted image, whereas on T1 weighted image it may show variable signal and may appear isointense to gray matter as is seen in this case, or it may be hypointense or even hyperintense depending upon the amount of myelin deposited. It is important to differentiate hypomyelinating leukodystrophies from demyelinating leukodystrophies. The white matter signal in demyelinating leukodystrophies shows more conspicuous hyperintensities as compared to hypomyelinating leukodystrophies, which have only a mild hyperintense signal of the white matter on T2 weighted image. Moreover, on T1 weighted image as well, the hypomyelinating leukodystrophies may have variable signal, whereas demyelinating leukodystrophies nearly almost always show hypointense signal of the white matter. Whenever we are labeling a patient with hypomyelination, it is important that we have a repeat scan at least 6 months apart. This is especially important if the first scan is done at less than 1 year of age. This is because many of these patients who may initially show deficiency in the myelination on the first scan may actually catch up and show normal myelination on a later scan. So this term is defined as delayed myelination, and can be caused due to various congenital or acquired deficiencies of vitamin B12, iron folate deficiency, or it can be associated with hypothyroidism as an MCT8 mutation. So it is important to recognize delayed myelination because many of these causes can be treatable and can be helpful to the patient. However, in a child over 2 years of age, if there is a severe myelin deficiency, it is more likely to result in permanent hypomyelination, and in such cases, we may not require an interval scan to confirm the diagnosis. Myelin sheath is formed from oligodendrocytes in an energy-consuming, organized process which involves interaction with astrocytes as well as growth factors and transcription factors. Therefore, hypomyelination does not occur only due to disorders of myelin structure, for example, myelin structural proteins, but also secondary to disorders affecting cytoskeletal protein of oligodendrocytes, disorders affecting gap junction proteins for oligodendrocyte astrocyte coupling, disorders affecting translation transcription machinery, disorders affecting transcription factors, growth factors, and DNA nucleotide excision repair defects. In addition to the primary hypomyelinating leukodystrophies, we may have secondary hypomyelinating leukodystrophies, which occur due to early neuronal loss. Here, myelin deficiency is not due to primary myelin loss, but it is due to the neuronal loss that leads to secondary myelin deficiency and can be seen in certain lysosomal storage disorders. Clinically, primary hypomyelinating leukodystrophies, the children present with psychomotor regression. They have global developmental delay with prominent motor dysfunction, spasticity, nystagmus, and ataxia. However, cognition is usually preserved and these patients maintain good visual contact. Epilepsy is rare, whereas secondary hypomyelinating leukodystrophies have more severe clinical picture. These patients have severe global developmental delay. They often have epilepsy and may present with severe epileptic encephalopathy, and these children usually maintain poor visual contact. On imaging, primary hypomyelinating leukodystrophies can show cerebral atrophy, but this happens usually later in the course of most diseases, especially if we image the patients when they are older or they are in adult age. Secondary hypomyelinating leukodystrophies, on the other hand, they have neurodegenerative features and with predominant atrophy of neuroparenchyma even in the earlier stages of the disease. Apart from the general clinical features which we discussed, including nystagmus, ataxia, global developmental delay, there may be certain specific features seen in various hypomyelinating leukodystrophies which can help us in narrowing the differential diagnosis. We'll study these clinical features as we discuss various hypomyelinating leukodystrophies. Whenever we are assessing hypomyelinating leukodystrophies, T1 and T2 weighted sequences remain the principal ones to assess hypomyelination. Apart from that, susceptibility weighted imaging may be quite useful to detect mineralization and calcifications. However, certain cases may not show blooming on SWI but may show calcifications on non-contrast CT brain. So whenever we are strongly suspecting calcifications in hypomyelinating leukodystrophies, we may additionally require a non-contrast CT brain in addition to the MR scan. Apart from that, a 3D heavily T2-weighted sequence may be added at the level of internal auditory canal whenever the patients with suspected hypomyelinating leukodystrophies have a clinical history of sensory neural hearing loss to detect any inner ear anomalies which can be associated with certain hypomyelinating leukodystrophies. MRS may be useful in certain cases, for example, Sal's disease, which we will discuss in the subsequent slides. So apart from the routine sequences, there are certain advanced MR sequences which can help in myelin quantification. These include myelin water fraction, magnetization transfer imaging, TTI, and calculation of G ratio. However, the disadvantage is that these are time consuming and are limited to research purposes. Another method of myelin quantification is synthetic MR. It has advantages over other methods in that it has a much shorter acquisition time as well as it requires a post-processing of even less than 1 minute. It can generate color-coded myelin maps. In addition, it can provide myelin quantification, myelin volumes, and myelin correlated parenchymal fractions, which is the fraction of myelin concentration over brain parenchymal volume. We can compare the myelin correlated parenchymal fraction of a patient with the age-matched controls as well with this method. Coming to the MR features, we'll discuss a pattern-based approach to hypomyelinating leukodystrophies. We'll discuss the patterns on T2-weighted sequence, considering this as the normal appearance of the brain with hypointense signal of the white matter. The first pattern is diffuse hypomyelination, where the entire white matter shows mildly hyperintense signal. The other pattern is hypomyelination, but with sparing of certain structures. For example, here the posterior limb of internal capsule and the optic radiations are spared. Other pattern can be where only certain white matter structures are involved. For example, only the optic radiation and posterior limb of internal capsule are involved here. Whereas in this case, there is diffuse hypomyelination, but there is more conspicuous involvement of the periventricular white matter. Apart from the white matter involvement, the patterns can also be divided based upon the involvement of other brain structures. For example, there may be hypomyelination with cerebellar atrophy. There may be hypomyelination with brainstem involvement. There may be hypomyelination with T2 hypointense signal of the thalami. There may be hypomyelination with basal ganglia involvement, where basal ganglia may be hyperintense, or they may show atrophy, or may show hypointense signal with hyperintensities as well. Or there may be hypomyelination with calcifications. So based on these patterns along with the clinical clues, we'll discuss various hypomyelinating leukodystrophies. This table shows various diseases falling under each of these patterns. So whenever we are approaching hypomyelinating leukodystrophies, first of all we have to identify whether it is hypomyelination, demyelination or delayed myelination. Then we have to have a broad MR classification. Then we have to look for any specific or additional clinical feature and any specific MR feature that may be present in a particular hypomyelinating leukodystrophy. Also, we may look at another important features which may be present in these hypomyelinating leukodystrophies. Beginning with the first pattern, that is diffuse hypomyelination. Palacios-Murspecka disease is the prototype hypomyelinating leukodystrophy which shows diffuse hypomyelination. It is an X-linked recessive disease caused due to pathogenic mutations in the PLP gene, which is the structural myelin protein gene. Now on MR, we see diffuse hypomyelination, but there are certain specific features. For example, there is sparing of the ventral brainstem except for the corticospinal tract. There may be also sparing of the basal ganglia and the deep grey nuclei. Now, since it is an X-linked recessive disorder, it predominantly affects the males in the late infantile period. On a continuum from the most severe to the least severe forms, PMD can occur as various phenotypes. The most common one being the classic PMD, whereas the most severe one is the congenital PMD, which is associated with missense mutations, has poor survival rates, and may affect females as well. Classic PMD is associated with PLP duplication mutations on MR. In addition to diffuse hypomyelination, it shows preserved myelin in early myelinating structures. PLP deletion mutations can lead to PLP null disease, which is similar to milder forms of PMD, but additionally can have peripheral neuropathy. On MRS, we may see a reduction in PMD null disease where we have deletion mutations, and we may see an increase in NA in the classic PMD where we have duplication mutations. On neuropathology, the classic form is known to show a tigroid pattern, which is basically preserved myelin in perivascular locations. This pattern may be difficult to see on MR but has been described in initial studies. A close differential of Palliasis-Merzbacher disease is Palliasis-Merzbacher-like disease. It has a milder clinical course than PMD. It is autosomal recessive as compared to X-linked recessive in PMD. It is caused by mutations affecting the cap junction proteins called connexins, the most common mutation being JGC2. On MR, we see diffuse hypomyelination, but as compared to PMD, which showed sparing of the ventral brainstem, there is involvement of both the ventral and dorsal brainstem in PMLD. An additional clinical feature may be peripheral neuropathy in these patients. Another disease with diffuse hypomyelination is Sala's disease, in which we almost always see significant corpus callosal atrophy. It is an autosomal recessive lysosomal storage disorder which leads to accumulation of free sialic acid in the lysosomes. Since it is a lysosomal storage disorder, patients have four phases. On MR, we see diffuse hypomyelination, severe corpus callosal atrophy, relatively preserved cerebellum, but one of the characteristic features which is seen on MRS due to accumulation of sialic acids is the presence of tall Na-like peak. The next disease in which we can have associated peripheral neuropathy, central dysmyelination, Waardenburg syndrome, Hirschsprung disease, and is due to SOX10 gene mutation is the SOX10-associated PCWH syndrome. These patients can have sensory neural hearing loss, and on MR, we see diffuse hypomyelination in addition to inner ear anomalies. Another important pattern of hypomyelinating leukodystrophies is hypomyelination with selective white matter sparing, which can be seen in polar 3-related leukodystrophy. Polar 3-related leukodystrophy is an autosomal recessive disorder caused by pathogenic variants in genes encoding RNA polymerase III. It can affect polar 3A, polar 3B, or polar 1C subunits of RNA polymerase III. Now, there are certain characteristic MRI features which can be seen in these patients. There is diffuse hypomyelination, but apart from that, there is preserved myelin, that is sparing of certain white matter structures, which are seen as T2 hypointense on a background of diffuse hypomyelination, T2 hyperintensity. These T2 hypointense structures which can be seen are optic radiations, pyramidal tract of posterior limb of internal capsule, and medial lemniscus. Also, T2 hypointensity may be present in the globus pallidi, ventrolateral thalami, and dentate nuclei. These patients may have variable corpus callosal atrophy and early cerebellar atrophy. Apart from the specific MR features, polar 3-related leukodystrophies may be associated with certain specific clinical features as well. For example, in this case, taken from literature, we are able to see that the child has hypodontia, but in addition, MR shows diffuse hypomyelination, marked cerebellar and corpus callosal atrophy, and a specific feature that is presence of preserved islands of myelin in the occipital white matter along the optic radiation as well as in the frontal white matter. So these characteristic features of polar 3-related leukodystrophy on MR along with hypodontia and another feature of hypogonadotropic hypogonadism can be seen in a syndrome which is known as 4H syndrome. All these features may not be present in the same patient, but when present, they strongly suggest polar 3-related leukodystrophies. In addition, certain features may be present in different types of polar 3-related leukodystrophies. For example, corpus callosal atrophy is more commonly present in polar 3A related leukodystrophy. In polar 3B involvement, cerebellar atrophy is more prominent, and in polar 1C, T2 hypointensity in the substantia nigra and subthalamic nuclei may additionally be present. Another pattern of hypomyelinating leukodystrophies is hypomyelination with selective white matter involvement. In this, the first disease is hypomyelination of early myelinating structure. Now, in this disorder, there is presence of T2 hyperintensity involving the early myelinating structures, for example, pericentral white matter, involving the posterior limb of internal capsule and involving the dorsal brainstem. These are those structures which show early myelination as we saw in the initial slides. Now, apart from these features, there is also presence of a characteristic trilaminar appearance to the posterior limb of internal capsule where there is alternating hyper, hypo and hyper intensity. This can be very specific for this disorder, although this is very rare, but when present, we can suggest this diagnosis. Another hypomyelinating leukodystrophy with involvement of certain specific white matter structures is hypomyelination with congenital cataract, where the patients, in addition to having congenital cataracts, can have peripheral neuropathy. On MR, what we see is diffuse hypomyelination, but there is also additionally presence of more conspicuous hyperintensities in the periventricular white matter. The other pattern is hypomyelination with basal ganglia involvement. Basal ganglia involvement can be seen as T2 hyperintensity, atrophy, or T2 hypointensity. The first pattern, where there is T2 hyperintense basal ganglia, can be seen in infantile onset GM1 GM2 gangliosidosis. These are lysosomal storage disorders, and these patients have coarse faces. They have hepatosplenomegaly, nephromegaly. In addition, can have cherry red spot in the macula. What we see on MR is the presence of T2 hyperintense basal ganglia along with diffuse hypomyelination. There is characteristically preserved corpus callosum. In addition, there may be presence of T2 hypointense signal of the thalami, especially on the ventrolateral aspect. Another disease affecting the basal ganglia with the presence of basal ganglia atrophy is hypomyelination with atrophy of basal ganglia and cerebellum. It is caused due to pathogenic mutations in the genes affecting cytoskeletal protein of oligodendrocytes, most commonly TUB4A gene. These patients, as the name suggests, show disproportionate basal ganglia, especially putaminal atrophy as well as cerebellar atrophy, disproportionate to the presence of hypomyelination. Now, this may also be seen as disappearing basal ganglia or disappearing putamen in these patients. And as the basal ganglia is affected, these patients have predominant extrapyramidal symptoms and dystonias in addition to the usual features of hypomyelinating leukodystrophies. Another hypomyelinating leukodystrophy with involvement of basal ganglia in the form of T2 hyperintensity of globus pallidus is fucosidosis. It is an autosomal recessive lysosomal storage disorder. Now, what differentiates it from other hypomyelinating leukodystrophies with T2 hyperintense globus pallidus is the presence of certain systemic features. For example, there may be skin abnormalities like angiokeratoma diffusum corporis. There may be skeletal dysostosis. There may be presence of hepatosplenomegaly, cardiomegaly, and recurrent infections. There is also one feature described for the globus pallidi hypointensities in this disorder. There may be alternating hypo and hyperintensities in the globus pallidi in fucosidosis, which may be a specific feature on a background of hypomyelination and may help us to reach the diagnosis in a specific clinical scenario. Then we have already studied many of these disorders showing hypomyelination with T2 hypointense thalami, including POLA3-related hypomyelinating leukodystrophy and various storage disorders. One such storage disorder is neuronal steroid lipofuscinosis, which is a secondary hypomyelinating leukodystrophy. There is a lot of diffuse cerebral and cerebellar atrophy, which is out of proportion to the presence of periventricular hyperintensities. The periventricular hyperintensities in these disorders are likely to represent hypomyelination, and there is associated T2 hypointensity of the thalami. So whenever we encounter T2 hypointense thalami in patients with hypomyelinating leukodystrophies, we can look at the basal ganglia. If it is hyperintense and there is preserved corpus callosum, it can be infantile onset GM1, GM2 gangliosidosis, of course, on a suitable clinical background. If it is not so, then look at the hypointense globus pallidi. If they are hypointense and there is presence of T2 hyperintensity in the medial and lateral medullary lamina of basal ganglia, it can be fucocytosis. It may or may not be hypointense, but there is basal ganglia atrophy, then it is HAPC. When none of these are present, still there is presence of hypointense globus pallidi, then it can be polar-related hypomyelinating leukodystrophy, and these may show selective white matter sparing. We can also have hypomyelination with cerebellar atrophy, as we already saw in polar-related disorders, in HAPC, in LCL. In addition, certain rare disorders like oculodentodigital dysplasia and 18q deletion syndromes can show cerebellar atrophy, but they have various associated clinical features which can help in clinching the diagnosis. Also, it can be seen in Cockayne syndrome, which we are going to see in the subsequent slides. So whenever cerebellar atrophy is associated with hypomyelinating leukodystrophy, look for the presence of calcifications. If there are no calcifications and there are ear anomalies, there is presence of sensorineural hearing loss, it may be 18q deletion syndrome. If there are no such anomalies and there is no presence of calcification but there is significant basal ganglia atrophy, it can be HAVC. Whenever there is presence of calcifications associated cerebellar atrophy. These can be seen in Cockayne syndrome, Tay syndrome, or oculodentodigital dysplasia syndromes, and these are various clinical features which can help in clinching the diagnosis. We can also have hypomyelination with brainstem involvement, as we saw in PMLD, where there was involvement of both ventral and dorsal brainstem, as opposed to PMD, where ventral brainstem was spared except for the corticospinal tract. Also, we can see dorsal brainstem involvement in HEMS, as we saw in earlier slides. A characteristic pattern of ventral brainstem involvement, along with periventricular hyperintensities and corticospinal tract involvement in the spinal cord, can be seen with another hypomyelinating leukodystrophy, which is known as hypomyelination with brainstem and spinal cord involvement and leg spasticity, that is HPSL. It is caused due to the sense mutations in the DARS gene, and it has striking resemblance to the mitochondrial DARS2 gene mutation, which is seen in LPSL disorder. These patients have severe spasticity in the first year of life and often present with motor paraparesis. Hypomyelination can be present with calcifications, as can be seen with Cockayne syndrome. Tay syndrome. In Tay syndrome, there is characteristic photosensitivity and hair abnormalities and oculodentodigital dysplasias, which can show ocular, dental, and digital anomalies. Cockayne syndrome, it is an autosomal recessive multisystem disorder which is characterized by DNA nucleotide excision repair defect. On MR, it shows diffuse hypomyelination with cerebral and cerebellar atrophy as well as corpus callosal atrophy. What is characteristically present is the presence of calcifications, which are usually homogeneous, affecting bilateral basal ganglia, predominantly the putamen. Another pattern of calcifications can be along the depth of cerebral sulci, though these are more associated with a more severe form of the disorder. These calcifications may not be detected, especially if the child is very small, especially less than 3 years of age, and we may require a non-contrast CT to detect them. These patients also show characteristic clinical features like cutaneous photosensitivity. They have characteristic progeroid faces and may have retinal pigmentary abnormalities. A close differential of Cockayne syndrome is Aicardi-Goutieres syndrome, where there is marked cerebral and cerebellar atrophy along with calcifications, but these calcifications are usually more heterogeneous and are also present in the periventricular location. Apart from that, the hyperintensity seen in these disorders are more likely to be demyelinating rather than hypomyelinating leukodystrophy. Also, there may be presence of anterior temporal cyst or prominent extra-axial spaces in the anterior temporal regions, which again make them a close differential of torch infections as well. Hypomyelination may be associated with very rare disorders as well. For example, this is a case of T-Parsi syndrome, where in addition to white matter hyperintensities which represent hypomyelination, there is presence of lot of tortuous veins as well as arteries. This patient also showed Permian bones. It turned out to be cutis lax autosomal recessive type 3A on genetic evaluation. Coming towards the algorithm for MR approach to hypomyelitic leukodystrophies, it looks very complex, so let us break it up. So whenever we encounter any patient with myelin deficiency on MR, we have to confirm whether it is hypomyelitic leukodystrophy by seeing the same pattern of deficient myelin on two MR scans 6 months apart, with one of the scans done above 1 year of age. If it is so, then it is hypomyelitic leukodystrophy. If there is improved myelination on the follow-up scan, then it is delayed or catch-up myelination. Once we are confirmed about hypomyelitic leukodystrophy, if there is only involvement of the early myelinating structure, then it can be HEMS. If it is not and there is diffuse hypomyelination, and this diffuse hypomyelination has predominant periventricular involvement with predominant cerebellar atrophy, not much of hyperintensities, then it can be NCL. If there is presence of cataracts along with peripheral neuropathy and this diffuse hypomyelination has more conspicuous periventricular T2 hyperintensities, then it can be hypomyelination with congenital cataract. When none of this is present, that means it is diffuse hypomyelination. Then we have to look at certain other structures. For example, if there is selective white matter sparing, then it can be Pol-3 related hypomyelitic leukodystrophies. If there is T2 hypointense thalami, then we have to look at the basal ganglia. And as we discussed earlier, depending upon the presence of hyperintensity or hypointensity of the basal ganglia or basal ganglia atrophy, we can classify these disorders. Whenever there is presence of cerebellar atrophy, look for the presence of calcifications. Those with calcifications can be differentiated based on certain clinical features, and those without calcifications may have atrophy of the basal ganglia as can be seen in HAPC, or they may have sensory neural hearing abnormalities, or they can have multi-organ anomalies as can be seen in 18q deletion syndrome. When above features are also not present, look for spinal cord involvement, which can be seen in HPSL. Look for NA-like peak on MRS, which can be seen in Salas disease. When these are also not present, look for any systemic features like Hirschsprung disease with associated peripheral neuropathy and sensory neural hearing loss, which can be seen in Stockton-associated PCWH. When none of these are present, look for the brainstem involvement, and after ruling out ODTT and HPSL, we are left with PMD, which is the prototype HLD, and PMLD. When ventral brainstem is also involved, in addition to the dorsal brainstem, it is PMLD. When the ventral brainstem is spared except for the corticospinal tract, it is PMD. So it is a complex algorithm, but we can keep it while reporting so that we are able to reach to a certain diagnosis with the help of MR patterns and clinical clues. Similar algorithm, which is more comprehensive, has also been given in this wonderful article, and we can refer to this as well while reporting hypomyelinating leukodystrophies. To conclude, MR plays a pivotal role in the evaluation of hypomyelinating leukodystrophies and is the primary imaging modality of choice. A unified and methodical approach combining clinical clues and MR patterns provide an improved understanding of these rare yet important disorders, enhancing diagnostic precision and improving patient outcomes. There is a lot of overlap present in these disorders. However, whenever we have a definite clinico-radiological characterization, this can be very helpful, especially if the patients have negative genetics or they have variants of uncertain significance or the genotypes are not matching with the phenotypes. In addition, advanced MR imaging techniques hold promise in prognosticating and monitoring the effects of novel emerging therapies in these patients, probably in near future. Before ending, let us have a quick recap of the very commonly seen hypomyelinating leukodystrophies. This is the prototype hypomyelinating leukodystrophy with diffuse hypomyelination but sparing of the ventral brainstem except for the corticospinal tract. This is Palacios-Merzbacher disease. As compared to the Palacios-Merzbacher disease, there is also involvement of the ventral brainstem in addition to the dorsal brainstem in this hypomyelinating leukodystrophy, which has a milder course than PMD, and this is Palacios-Merzbacher-like disease. Then we have diffuse hypomyelination, but there is sparing of certain white matter structures, example optic radiations, pyramidal tract of internal capsule, and medial lemniscus. In addition, there is corpus callosal and cerebellar atrophy, and GP hypointensity and hypointense thalami. So this is polar 3 related leukodystrophy. It has a very important clinical association as well, and when present, it can be specific for the diagnosis, and that syndrome is presence of hypotonchia and hypogonadotropic hypogonadism along with hypomyelination, that is 4H syndrome. Then we can have patients with coarse faces, cherry red macula, and hepatosplenomegaly. And on MR, we see diffuse hypomyelination and hyperintense basal ganglia with preserved corpus callosum and hypointensity of the thalami. This is seen in infantile onset GM1, GM2 gangliocytosis. And the last pattern, which you must remember and easy to remember as well, as the name suggests, there is disproportionate atrophy of the basal ganglia and cerebellum along with hypomyelination in these patients with hypomyelination with atrophy of basal ganglia and cerebellum. So these are few good reads for this topic. I thank Spin Academics and Dr. Kish for giving me this wonderful opportunity. I thank my mentors, Dr. Bijoy sir, Dr. Keshav sir, and Dr. Soumya ma'am for helping me with this presentation, and also my entire department and Department of Neurology for helping me with the case collection. And thank you all for your patient listening. Wish you a Merry Christmas and a very Happy New Year, and happy learning to you all. Thank you so much.